I've been asked to give an update on sort of perioperative management of sickle cell disease, and I thought I'd focus on trying to give a haematologist perspective, as I know many of you are already very familiar with this patient group. The latest standards for the clinical care of adults with sickle cell disease was published in 2018, and it says that all hospitals should have a protocol in place for preoperative screening for sickle cell disease. All hospitals should have a protocol in place for perioperative management. And as Stephen mentioned, we've recently updated that, and that is now available on COHA, and that sort of takes into account much of what I'm going to say today. One of the key points is for patients with sickle cell anemia having low or medium risk surgery, they should be offered either a top-up transfusion if their hemoglobin is less than 90, or a partial exchange transfusion if the HB is more than 90. And I'll sort of show you the evidence for that in a bit. If they're undergoing low or medium risk surgery, and if they're undergoing high risk surgery, then all patients with sickle cell disease, whether they are SS or other genotypes, should be offered an exchange transfusion. And the sort of indications for non-sickle cell anemia genotypes in terms of transfusion for low and moderate risk surgery is more on a case-by-case basis. There's also this guideline that was published in 2021 by Anaesthesia, which sort of gives more of a anaesthetic slant and things, which is also really good to review. So I think everyone knows the main pathophysiology of sickle cell, combination of acute vaso-occlusive episodes and chronic hemolysis. This leads to acute and chronic organ damage. There's various different forms of sickle cell diseases, as you all are familiar with. Sickle cell anemia, HBSS, being the most severe. As I'm sure you all know, there's a combination of organ damages that can happen in many tissues throughout the body, and it's a multi-system disease. So when seeing people for surgery, we need to consider all of these potential problems, and that patients can have either clinically obvious complications in these organs, or potentially evidence that may not be completely apparent. For example, kidney dysfunction is one such area, because of patients with sickle cell having sort of a hyperdynamic state. They tend to sort of have hyperfiltration of their kidneys, and therefore once their creatinine is within normal levels for age, that would already be a sign that they have got some element of chronic kidney disease. There's a range of different acute complications which patients with sickle cell disease can get. I'm sure many of you have seen some of these complications. Painful crisis, the most common, but acute chest syndrome is also commonly seen. I know we've had, over the years since I've been here, several patients requiring CCD and intensive care for that. Neurological complications is also unfortunately quite common, and things such as sequestration. Chronic related complications, as I've said, it's a multi-system disorder. Many patients have renal dysfunction. Unfortunately, a lot of patients also have significant cardiorespiratory issues. As I'm sure many of you have been involved with, unfortunately, we get lots of patients with osteonecrosis requiring total hip replacement at a young age. And there's all of the other complications related to transfusion and red cell antibodies, and an increased risk of infection due to hyposplenism, but also probably due to bacterial translocation from the gut due to sickling within the bowel. So just to give you a bit of background of how sort of hemoglobinopathy services work. So in Nottingham, we're what's called a specialist hemoglobinopathy team. So we look after patients across the north part of the Midlands. So as well as covering Nottingham, we also support services at Derbyshire and Lincolnshire. And for many indications such as high risk pregnancy, complex surgery, patients from Lincoln and Derby would come here to have those procedures. So this was a good little quick crib sheet that I found in the paper mentioned below, which highlights that preoperative assessment and planning is absolutely key. And that's because, as I've already mentioned, we know these patients have organ damage and at a higher risk of complications, as you all know. And I know this is already something that you guys are really excellent at doing. We have good collaboration to get patients seen preoperatively in anaesthetic clinic, to think about many of these risks, including problems with managing pain, risk of sepsis, VTE, and preventing chest crisis. So we know that patients have an increased risk of chest syndrome post-surgery, and this is due to a range of complications from pain due to which leads to sort of hypoventilation. It can obviously be due to opiates, due to infection, splinting of the diaphragm due to pain, and also, obviously, as I've already mentioned, increased risk of infection. Unfortunately, patients do have an increased risk of stroke and these chronic complications, as I've mentioned in the background. So there was a good study which is worth, if anyone has the time. It's quite old now, but it was a study which was based on a cohort of patients in America. It's called the Cooperative study, and they basically had a big cohort of patients who they observed and did various analyses over many years. So one of these was done by Koshi et al, and it was published, like I say, quite a long time ago, but it does give some very good information about the risks and what type of surgery patients had and how that went. And as you can see, the mortality rate in the study was reported as 1% over the first 30 days post surgery, compared to on average over the 6-year follow-up a risk of 0.3%. Interestingly, quite a lot of the patients in the study were children and young adults, and there was no cases of mortality in that age group. So I suspect this is somewhat underestimating the potential risk. But they postulated from their study that the risk and complications were likely to be due to the acute tissue injury and chronic organ damage from vaso-occlusion, and that being exacerbated during surgery. So in our guidelines, it also recommends to try and help to risk assess patients preoperatively that they should have had an echo within the last 2 years. A chest X-ray is recommended, ECG, which I know is obviously standard, and also baseline oxygen saturations, because we know quite a few of our patients do have chronic hypoxia, which can be as a consequence of previous chest crisis and problems from that, leading to sort of restrictive lung disease. There's also an increased risk of obstructive sleep apnea in our patient group, so we always try to discuss and assess whether that could be something that patients suffer with, and we often know that's a risk factor for priapism and increased risk of severe migraine. So as part of all of this assessment and assessing the risk of the patient, obviously they may need higher level care and monitoring, which is something we routinely liaise on already preoperatively. And obviously, as you all know, obviously dehydration is not ideal for people with sickle cell, so we try to minimize the duration nil by mouth and get people done ideally early on in the list. And also, some of our patients do have complex pain needs, as I'm sure many of you are aware, and therefore it's important that we make a clear plan for analgesia preoperatively. We've got some, as I said, some updated guidelines which have recently been published. So we have an updated transfusion guideline, which includes lots of information regarding transfusion management of sickle cell disease. And has updates on managing complications of transfusion, such as hyperhemolysis, and I'll touch on that a bit shortly. And he also gives an overview of the differences between top-up transfusion and exchange transfusion, and also arranging an automated exchange versus a manual exchange. And I'm happy to send Stephen the specific links, but it does come up on COA. And as Stephen mentioned, we've got our updated perioperative management guideline. But what I'll do at the end, if there's time, is I can just show you one of our perioperative care plans if nobody's seen them before. And that's something we try to produce in advance of the surgery, so everyone's clear on the past medical history of the patient. And also, in most cases, we try to make some basic recommendations on patients' previous analgesia and what they generally find works for them. But obviously, I would always recommend that our teams follow your advice and guidance, as you are clearly very experienced in pain management and much more expert in that than myself. So the key things we look at intraoperatively, again, this is something that you guys I know do routinely and are much more expert in this area. So I won't sort of stay on this for too long. But these are all recommended in that anaesthesia article. And it does highlight that regional anaesthesia is a really good option and probably is lower risk. And I know we've had several patients with complex pain where your team has recommended, as well as a general anaesthetic, a regional anaesthetic alongside that to help with those complications. Obviously, thrombosis is increased risk in these patients, so we should always follow the trust guidelines for VTE prevention and operative bridging if patients are already on anticoagulation, and obviously the increased risk of infection and therefore prophylaxis guidelines should also be followed. Again, you guys are very helpful and very supportive of when our patients need CCD, them being admitted to your areas of higher dependency, and that may be required for some of our post-operative patients, but it may not be required for all patients, and it is appropriate in some circumstances for low-risk procedures with low-risk patients for them to have day case surgery. Other complications that can result following surgery include chest crisis, unfortunately multi-organ failure, and then some other reasons why patients might end up coming to CCD, not directly related to surgery, but unfortunately we have seen some of these cases in recent times, is there is an increased risk of stroke. There is a condition called fat embolism syndrome, which is generally seen in milder patients with sickle cell disease. But they get a sort of severe crisis with associated acute kidney dysfunction and also neurological consequences. And the management for that is an acute red cell exchange, but also considering plasma exchange, which has been shown in case reports to be helpful. I also just wanted to point out that we are unfortunately seeing a lot of cases of parvovirus this year. Touch wood, so far in adults we've not had any recognized cases, but certainly in pediatrics there's a lot of cases, and the patients do seem to be becoming much more unwell than we would normally expect just for transient red cell aplasia. A lot of the patients seem to be getting a hyperinflammatory syndrome and significant chest crisis. And that's even happening in people with a historically mild phenotype. So that's something to watch out for. Hopefully, like I say, we won't get lots of cases, but it does seem that parvovirus is particularly prevalent this year. So just covering a few points in a bit more detail. So as I mentioned, preoperative testing is essential. So we have a range of techniques that we use at NUH. So the quickest and easiest is sickle solubility test. This is where we essentially use the principle that hemoglobin S in its reduced state is less soluble in phosphate buffer than normal hemoglobin A, and therefore if you do a solubility test you can get a positive or negative result, as you see here. It does have a few slight pitfalls to it. It's not good when children are first born or if patients have potentially been extensively transfused outside of our hospital, as it only picks up hemoglobin S down to about 10%. It also is unable to differentiate trait from disease. So in an emergency setting, it can be helpful to exclude sickle cell disease, but it doesn't confirm, as it can't unfortunately differentiate carriers from sufferers. There can also be occasionally false negatives if patients are very anemic, and you can get some false positives due to various other pathologies that can be going on. Usually, if we do the technique correctly, however, these sort of cases can be avoided. These sort of false positives can be avoided. The main test that we do for confirming diagnosis at NUH is high performance liquid chromatography. Unfortunately, we don't have this available out of hours currently, so ideally we do need to have it's only being performed sort of during normal working hours, so we do need sort of 48 hours to be able to get this. Occasionally, if there is somebody in the lab trained, they can run it more urgently, and it's something that we're hoping to get available 24/7 in the relatively near future. So the main thing I thought I'd finish talking about is transfusion, and this is obviously more my area. So we know obviously from previous studies that transfusion decreases post-operative complications, and I'll show you a bit of the evidence for that. But obviously we know transfusion isn't without risk, and there's a risk of alloimmunization, there's a risk of what we call hyperhemolysis, there's a risk of infection, iron overload, and if we increase someone's hemoglobin, there's an increased risk of hyperviscosity complicating and causing problems from their sickle cell. So when deciding whether someone needs transfusion for their sickle cell disease preoperatively, we take into account patients' genotype, phenotype, their starting hemoglobin, and the type of surgery which is planned. So the reason transfusion is potentially more difficult in patients with sickle cell disease is that we know there's an increased risk of Rh variants, and also unfortunately a higher incidence of alloimmunization, so up to 30% in some studies. Most studies quote around 7 to 10%. And this is because unfortunately our donor pool is very different in terms of the red cell antigens that patients have compared to patients typically who have sickle cell disease. So we try to limit this as much as possible by matching our blood as closely as possible, matching for the Rh and Kell blood group systems. But unfortunately, we're not able to manage to optimize and match for all of the different blood group systems. So this just shows you that different Rh phenotype. So as you can see, R0, so D positive, little c positive, little e positive is the most common haplotype in Black patients, which is obviously our main group of patients with sickle cell disease, whereas unfortunately our donor pool is mainly white Caucasian, where you can say this is quite an unusual genotype. This does make providing blood for patients more tricky, and this is something that NHS BT is doing lots of work on. And to help us better match blood transfusion for patients with sickle cell disease, we're now doing a genotyping project. So we're genotyping patients so we get a better idea of what red cell antigens patients express. So this is a summary of some studies that have been done over the last 30 years, and you can see here that there is a range of the data is very variable, and the number of randomized controlled studies is very small historically, and the majority of the evidence has been based on observational studies. So you can see here the adverse events in Vachinsky et al. Showed that there's a risk of adverse events even in transfused patients of 1 in 3, and a 10% risk of acute chest syndrome. Interestingly, a further ARCT by Aljouni et al. Seemed to suggest that transfusion had more adverse events than untransfused, but the quality of the publication is quite poor. And also this study was based in Saudi Arabia, where it's appreciated that the clinical phenotype of patients is milder. So it sort of felt that's not necessarily applicable to other haplotypes of sickle cell anemia. I've mentioned the Koshi study already, and you can see here again that it showed a significant risk of complications in both transfused and untransfused, and a higher risk of chest syndrome in untransfused patients. And Haberkern was another study that was observational. It actually took the same cooperative data but looked at cholecystectomy. And you can see here that in untransfused patients, there was, a doubling of the risk of chest syndrome as opposed to not transfusing. So British Society of Haematology took into account this guidance in terms of their recommendations, and their recommendations are to offer all SS patients low or medium risk surgery, a simple or exchange transfusion based on their starting hemoglobin, and I'll show you the evidence for that in a second, and also to consider exchange transfusion for SC patients for medium risk surgery, and all sickle cell genotypes should be offered an exchange transfusion for high risk surgery. So I think I've covered that study. I've mentioned about Vasinci. So this just shows you that Vasinci data in a bit more detail, and you can see that the difference that there wasn't actually felt to be any difference between conservative transfusion, i.e. top up, and aggressive transfusion. And so that led to there being further thoughts about, does all patients, particularly for minor surgery, need to have transfusion in hemoglobin SS? So Dr. Joe Hard from Guy's and St Thomas's did this study called the TAP study, which is what most of our transfusion recommendations are now based on. So transfusion alternatives preoperatively in sickle cell disease, that was published in 2013. So this took patients with hemoglobin SS or hemoglobin S beta 0 thal, and it randomized patients. It was quite a brave study, really. It randomized patients to having either no transfusion or red cell transfusion. If they had a starting hemoglobin less than 90, then they had a top up. If they had a HB starting above 90, they'd have a partial exchange transfusion aiming for a hemoglobin S level less than 60%. And it was looking at patients with low or medium risk surgery, and there was the exclusion criteria as mentioned here. And they showed that there was no difference between the two patient groups. And you can see that the majority of patients were having medium risk surgery rather than low risk surgery. And a lot of the patients had either abdominal or ENT. And you can see that the hemoglobin on admission, as you'd expect, was higher in the patients who received transfusion. And you can see that the risks of this study showed that the rates of significant complications was reduced in the preoperative blood transfusion arm, and the risk of serious adverse events was also much reduced. And you can see most of the signal of why this occurred was due to a significantly increased risk of acute chest syndrome in the no blood transfusion arm. And the harms of transfusion were felt to generally be acceptable. There was one case of fresh alloimmunization, but also interestingly, obviously the idea of the study was if they could show that not transfusing patients was safe, then that would hopefully save people being transfused. But as you can see here, the patients who didn't have transfusion preoperatively ended up having it either intra or postoperatively. So you didn't save and avoid transfusion in these patient groups. And therefore, their recommendations that all patients having medium risk and low risk surgery who are HBSS should be offered a transfusion program as per this schedule, which is what we follow. So this just summarizes those transfusion recommendations that I've mentioned several times now. So just before I finish, I thought I'd briefly touch on emergency management, as this is something which obviously we have had experience at NUH of recently, unfortunately. So there's no real evidence to support what's the best approach here. Generally, the recommendations is that we shouldn't delay surgery to arrange transfusion. If the situation does allow and the hemoglobin is less than 90, it's reasonable to start a top-up transfusion, either preoperatively or intraoperatively. If obviously time does allow and the patient has a HB above 90 and they have significant clinical phenotype or HBS, an exchange transfusion is ideally optimal, but if not, this can be carried out post-operatively. And in patients who are very anemic or having major hemorrhage, then frequent top-up transfusions is more than acceptable, as they will dilute the patient's hemoglobin S level and essentially avoid the need for exchange. So we do now have automated red cell exchange available at City Hospital 24 hours a day as of the start of this month. So if there is any urgent need for exchange, that can be done at City. Unfortunately, we don't still have automated exchange at QMC. So if an exchange is required for certain emergencies, the most likely of that is likely to be for neurological complications or major trauma. Then we would need to do a manual exchange until patients are fit for transfer. And the protocol for that is in our guidance. In terms of difficult to transfuse patients, these should obviously be managed in an MDT approach and optimizing with eperitin, hematinic replacement, optimizing patients' hydroxycarbamide, considering voxelotor, and in patients who've had previous severe delayed hemolytic transfusion reactions or have a history of hyperhemolysis, where they essentially hemolyze hemolyze both their own red cells and their donated red cells. There's a clear protocol which is in our new transfusion guideline, where, providing time allows, we would give IV immunoglobulin, methylprednisolone, consider pre-treatment with rituximab. We'd also want to give the best possible matched blood, so we'd liaise with NHSBT to ensure that the blood is matched to patient genotype. And in the event of having to give inappropriate transfusion, we can use eculizumab and tocilizumab as bailout treatments if people do get severe hemolysis after transfusion. And then finally, I'll just mention a couple of lacking areas. So tourniquets is a big debate. Generally, we wouldn't recommend them being used routinely, but if someone's been exchanged preoperatively and they have a low hemoglobin S and they're being meticulously looked after, then it can be considered. And finally, cell salvage, again, we wouldn't probably routinely recommend this, but it can be considered if someone is, for example, unable to be transfused, or in the case of emergency urgent surgery, and it's felt that not, returning the blood would be potentially life-threatening.